symptoms of this one, but they are not typically classified as disorder of consciousness. That's a completely different entity in itself, locked-in syndrome. Also, we have to know that 1 in 6 patients who are classified as coma, vegetative state, or MCS minus have volitional brain activity that can be detected by task-based functional MRI or EEG. This is a state called cognitive motor dissociation, where the brain is probably functioning, but there's no way we can know about it because there's a motor dissociation. And this can be picked up by some of the scans, like a functional MRI that we told. And that is something we have to keep in mind, that since this is a clinical classification that we're talking about based on our clinical evaluation and patient responses, there is a 20% chance that we could be wrong, even if we get it, the clinical stuff very right. The acute disorder of consciousness is the first 28 days after injury, irrespective of the cause. It could be due to stroke, brain injury, hypoxic injury. The first 28 days is what you call the acute disorder of consciousness. The CRS scale is very comprehensive. We can't go further about it because it will take the whole day. So I've given a link to the CRS scale and the administration and scoring guidelines, which is actually, they have described everything that you need to know for evaluation of a patient with DOC. Coming to pathophysiology. So what causes a disorder of consciousness? Here you can see the cortex, frontal cortex, parietal cortex, then there's a thalamus, basal ganglia, and the brainstem. So there's a lot of synaptic activity happening around this reticular activating system. When there is a gross damage to the brain, it may not be 100%, but it's a gross damage, then there will be extensive withdrawal of excitatory synaptic activity across the cortex. And there will be direct structural loss of inputs, or there could be some reduced input to the cortical and thalamic neurons. In the end, they're not effective, and that causes this state. And what studies have shown is the recovery of consciousness is based on the functional re-emergence of these activation systems and sufficient input to depolarize the neocortical neurons. When that happens, we see the clinical changes. And metabolic activity and functional connectivity within these networks increase as patients transition from coma to recovery. So I hope we get basics of what are the different types of disorder of consciousness. And now we'll see the role of a physiatrist here. The primary goal is to provide evidence-based multidisciplinary rehabilitation care. Just like any other disorder, like someone has a stroke, diabetes, any other care, there is a certain care or model of care that has been prescribed. So even in DOC, there is a model of care that's prescribed. So to follow this evidence-based MDB is our #1 goal. With regard to the improvement of patients, the physicians, which may be the physiatrist or the ICU doctor, the neurologist who is taking care, have to provide a physiologic milieu for neurologic recovery. What it means is, if the patient has multiple infections, multiple metabolic abnormalities, so patients are not in a good physical state where we could concentrate on the neurological recovery, or all these complications can actually further hamper the chance of recovery. So the early identification of medical complications are required, and that is one of the goal. And like we're going to see further, like a lot of people won't recover from this state. So even for them, they have to go home or in a less intensive setup, and the cost involved is very high. So one of the goal is to take care of those complications so that further need of hospital readmissions come down. Also, refinement of the prognosis over the time so that we can take rational care decisions, and having connection to a specialized rehabilitation center is always a plus for these patients. And the #1 role of physiatrist is to provide medical stability before starting any rehabilitation program. The focus should be on the potential for recovery of consciousness. This you could say as the daily goal daily role of a physiatrist would be on a daily basis to ensure that the patient is medically stable for going for a therapy. The stimulus, the consciousness level can fluctuate over the time. So sufficient auditory, visual, or tactile stimulus must be provided to elicit responses. There could be 2 types of stimulus. We can give a peripheral stimuli, here we are looking, when you give a peripheral stimuli, that's basically on the interphalangeal joints, we're looking for an eye-opening response. Now, this interphalangeal joint pressure may elicit a spinal reflex, but that is not an indication of intact brain function. Now, if you want to look for a motor response, then you have to give a central painful stimulus. Here in central stimulus, we are stimulating a cranial nerve so that we are avoiding the spinal reflex and we can look for motor movements. The different stimuli are supraorbital pressure, jaw margin pressure, trapezius twist or sternal rub, all act in a different way. Before starting a comprehensive rehabilitation program, we have to know the events leading to disorder of consciousness and the duration, because the prognosis changes vastly between if it's a stroke, if it's a brain injury, if it's a hypoxic damage, if it was a metabolic injury, and the duration. The chances of recovery probably goes down with time, especially after the first 6 months. The history of length of stay in the ICU, what are the medical complications that had happened earlier? Someone who's already had multiple hyponatremias or infection has increased chance of them happening over the time. What interventional procedures were done earlier? Surgical interventions, maybe some shunt has been placed, SPC has been placed, whatever individual intervention procedures has been done earlier. This we need to know before starting the program. And observe the stationary position of the patient and attitude of the limbs, the breathing patterns and reflexes such as coughing, swallowing, the behavioral responses to stimuli. First, always try to provide a verbal command and look for the responses. If there are none, go for a non-noxious stimuli and then go for noxious stimuli. In patients with severe hypertonia, tone management is a must before assessing for fine motor movements. This is something we have seen clinically when patients with severe hypertonia, if at all we manage to have a better tone management, earlier some motor movements which were earlier present becomes apparent. And the earliest motor responses observed are blinking, jaw, or tongue movements, probably because their cranial nerves are being used and severe motor weakness hampers the further movements. The motor responses are that seen are decorticate posturing. So probably I've not put the images here because I'm assuming most people understand what's a decorticate posturing. It indicates a hemispheric damage with preservation of motor centers in the upper portion of the brainstem. So in all the responses, having a decorticate posturing is better than a decerebrate or flaccidity. And in decerebrate posturing indicates upper brainstem motor centers which facilitate this flexion to be damaged. So only the lower brainstem which facilitate extension are responding, and that's why we get a decerebrate posturing. And when there's extensive brainstem damage, patients present with flaccidity, or not just present, they continue to be in stage of flaccidity. Now there's a high rate of diagnosis error, close to 30-40% with non-standardized techniques of evaluation. And also the responses that we see are minimal, inconsistent, and exhaustible. That's why standardized scales are very important to assess, prognosticate, serially monitor, and the most commonly used is the coma recovery scale revised. But it is a lot of time consuming. So at least at the time of to make a diagnosis of the state of DOC, it is most useful. Glasgow Coma Scale, it is was developed to assess patients with head trauma, but it is very useful on a regular basis to serially monitor the patient's status, especially when the patient is in a coma state or vegetative state. There's another scale called a force scale that is used in coma patients in intensive care settings because they're easier to use than a CRS. While the role of brain imaging once the patient is already in coma is not as much, because it's till now we are not able to link find a link between who eventually makes a lot of prognosis improvement or not based on any brain scannings. But still, MRI can show the extent of structural brain damage, and a functional MRI can show motor independent response to simple commands. There's also diffusion tensor imaging that is useful to measure the axonal integrity. This can be indirect signs of potential recovery. transcranial magnetic stimulation EEG, there is another method that is actually available for the direct perturbation and recording of brain's response with high resolution. PET scans are furthermore commonly used, and they give a proxy measure of cerebral glucose consumption, thereby giving an approximation of functional tissue integrity. It's been seen that in coma, brain metabolism is reduced to about 50 to 70% of normal. In terms of management, first thing would be to identify the reversible contributing factors of impaired consciousness. So if you're strictly talking medical, then this would be the main role of a physiatrist to know what are the complications that can commonly happen and find them early and treat them. The common ones are the hyponatremia, find out which is a hypovolemic causes, and hypovolemic causes can be treated. Infections, most common are the UTI, aspiration pneumonia, pressure ulcers, and CNS infection. Some endocrine complications like SAIDH, diabetes insipidus, disturbed glucose metabolism, adrenal insufficiency are commonly seen. Most of the seizures are non-convulsive, and status epilepticus are also common. So the routine EEG is evaluated in these patients, and mostly they are on anti-epileptics. Hydrocephalus is not so common, but still one of the common neurosurgical causes for change in neurological status. So a patient who could be in DOC, maybe minimally conscious state, who was well alert, doing some kind of motor movements. Suddenly, if you see a change in neurological status, there's a fluctuating eye opening or change in sleep pattern, if there's unexplained vomiting or other features of raised ICP, hydrocephalus could be one of the causes. Now, there's another concept called detrimental drugs concept, which means there are certain medications which impair recovery of brain injury. Now, this is what we really want, the recovery of the brain injury in the end. So these drugs should certainly be avoided. Some of the commonly used ones are the haloperidol, prazosin, clonidine, benzodiazepines in general, fentanyl, and phenobarbital. And in terms of pharmacological management, there was a concern, or there might still be concern, that an early stimulant therapy might increase the risk of seizures in patients with acute DOC, but this has not been supported by the current evidence, and it's common practice by now that most of the patients we see in DOC are on multiple neurostimulants. Neurostimulants enhance the activity of neurotransmitters within the CNS. They increase synaptic concentration of dopamine, serotonin, noradrenaline in brain. They can enhance the arousal, wakefulness, awareness, attention, memory, mental processing speed, and motor processing speed. The only medicine that has been proven in multiple studies to be of some value, some definite value in terms of arousal, in terms of improving consciousness, is amantadine. It's shown that acceleration of recovery of consciousness in a randomized controlled trial of patients with DOC, and by now it's common that most patients are on amantadine. Other medications less commonly used are levodopa, or equally used are modafinil, methylphenidate, bromocriptine, and amphetamine. Zolpidem is a GABAergic medication with a paradoxical awakening effect in some patients with subacute to chronic DOC. Even we use in our center some of patients zolpidem either to induce sleep, and they might have some paradoxical effect as well. What are other complications that can happen? In patients with disorder of consciousness, it's especially in the first 3 months, it is very common for them to have severe autonomic dysfunction, which is now called the paroxysmal sympathetic hyperactivity syndrome, PSH. What happens is that they have frequent bouts of paroxysmal tachycardia, hypertension, tachypnea, hyperthermia, and posturing episodes with a lot of diaphoresis. It is a very tricky situation where one could get alarmed, because it could as well be anything else, where the patient is in a lot of distress and causes a lot of anxiety in the ward or home to the patients as well as relatives. And so at least the right identification of the syndrome can help the patients and family to know that this is just, I'm not say just, but it's a feature of autonomic dysfunction, and it will come down on its own. There are certain medications that we can use like morphine, bromocriptine, propranolol, and clonidine, which have been found to be effective to some level. Another complication seen particularly in this kind of patients are central fever, which is a non-infectious type of fever due to direct damage to the thermoregulatory centers. Acetaminophen, NSAIDs, bromocriptine, baclofen, and morphine are indicated here, and seems to work pretty fine, especially in chronic conditions. Bladder-related complications are one of the most common triggers for infection as well as autonomic dysfunction, and they are UTI. And if patients are off catheter, we can see a lot of symptoms of overactive bladder syndrome, hematuria, bladder stones, strictures, orchitis, are the common complications in this population. Constipation is very common due to immobility, prolonged supine position, a lot of anticholinergic medications, tube feeding, dehydration, lack of fiber in diet. Incomplete eyelid closure and lack of lubrication can lead to corneal damage. So that is a very preventable complication, especially in the ICU and the early time of rehab, which can be done with lubrication and eye taping. A good musculoskeletal health is required for positioning of the patient, mobilization, and adequate therapy. The common cause of hypotonia is spasticity, dystonia, rigidity, a mixture of all three probably, and their management is one of the major roles in what we see in a OPD or IP setup in rehabilitation. We're using definitely the drugs, whatever we have in spasticity control, which I'm not going to because that is something related to spasticity control, all the medications, exercise, weight bearing, casting, baclofen, Botox, or benzodiazepine, any other medicines. So management of hypertonia is paramount to prevent contracture and have a good therapy. Heterotropic ossification is won't say common, but you need to have a high index of suspicion for this, where the patients might present with joint swelling or a change in pain pattern during range of motion, or they could be a trigger for sympathetic overactivity. There's a study that showed like 14% of patients in severe brain injury had history of HO. So once we try to find out the complications, what are the things that a physiatrist can do in this case? If the patient is in an MCS condition, then it would make sense to establish AAC, alternate augmented communication techniques that's available that can improve the patient participation and establish interaction between patients and caretakers. A simple yes-no charts, picture charts, or advanced machines like eye tracking machines can be used to establishing a communication strategy. Then typically prescription of orthoses, AFOs, knee gaiters, elbow gaiters, hand sprints work less, but still, and a reclining wheelchair. Educating the family member, training them for the red flag signs, training them for home-based rehab program. And lastly, prognosticating. Most patients do not make meaningful recovery, and it's good to know that, but some patients make dramatic improvements at different stages of time based on multiple factors like etiology, duration of the injury, and the age of the patient. So avoid an overly pessimistic prediction that may lead to eventually patient getting less care and more complications. Also, there is a tendency to depend a lot on neuroimaging data. So avoiding misinterpretation of this data would be a good thing. Another role, especially this is we see in more of private hospitals and centers with good neurological support, are decannulation. That is upon the physiatrist these days to take a call on when to have a decannulation or whether or not to decannulate basically. So patient presents with a tracheostomy tube into the rehabilitation center, and there are two goals of why the patient would have been on tracheostomy, probably because of severe dysphagia and aspirations and for the need of a mechanical ventilator. But let's say at a 1 month time or after that, this is used mostly for suctioning the tracheal secretions and protecting the aspirations. So once we can manage the secretions adequately, medically, and by using any other methods, and once we find that dysphagia has improved and patient is able to at least swallow his own saliva, then we can think of removing the tracheostomy tube. Why? Because the tracheostomy tube in itself can cause microaspirations, dysphagia, worsening the dysphagia, can be a cause of pain. And in prolonged cases, there could be granulation tissue at the site of the tracheostomy, which can further, at a later point of stage, impair the decannulation process. Dye test is the objective used to objectively assess the risk of aspiration in patients with tracheostomy tube, where usually a therapist, a swallow therapist, or even a nursing or yourself, you can put a colored dye through orally, and after 30 seconds, suction from the tracheostomy tube and look for the dye in color. That would say that patient is probably aspirating. A more advanced method would be a video fluoroscopic swallow study, also known as modified barium study, where fluid of various consistencies mixed with barium are given orally. It is a direct dynamic view of oral, pharyngeal, and upper esophageal function, and can be quite useful before going for a tracheostomy tube removal. Once the plan of removal has been done, and once you take after discussion with the family and seeing the patient's overall condition, we can evaluate the tolerance in patients who demonstrate adequate swallow function by decreasing the tube size gradually and increasing the TT block duration. And if the patient can tolerate both of these, probably can go for decannulation. Now, in general, we'll see what are the other rehabilitation measures where we might not have an active role, but the patients could make some kind of recovery. So it has been postulated that broadly inadequate stimulation and inadequate mobilization can hinder the possible recovery. So measures to stimulate the intact but suppressed brain networks responsible for consciousness can lead to recovery. So therapies aimed at this to increase the mobilization and increase stimulation. What are they? They could be mobilization, assisted sitting, assisted standing. In terms of improving stimulation, there could be visual stimulation, auditory, olfactory, gustatory, cutaneous, kinesthetic, and even assisted gait as a form of stimulation to trigger neuroplasticity or improve consciousness. And there is always the preventive therapy to prevent contracture spasticity and improving postural control. Some of the other things that happen that have been used in certain centers for improving consciousness, or in general in patients with a disorder of consciousness, are hyperbaric oxygen therapy. So it is basically inhalation of 100% oxygen under the pressure greater than 180 A. It could be 1.5 to, in some centers, 2.5 for a shorter duration. And how it works, it's supposed to suppress the inflammation and promote angiogenesis and neurogenesis, which may lead to improving consciousness or improvement in these patients. The prerequisites for hyperbaric oxygen therapy are cardiopulmonary stability, intracranial pressure stability, minimal suction requirements, because we're putting the patient in a chamber where we won't have access to the patients immediately. And since there's a lot of pressure changes involved, history of lung diseases, ear diseases, or any uncontrolled seizure has to be ruled out. Proposed benefits are improved alertness, and a Cochrane review has shown that overall it reduces the risk of death in a long term. Different electrophysiological methods we have are neuromodulation techniques, which aims at normalizing the neurophysiologic disturbances produced by brain dysfunction by targeting the neural circuits with electromagnetic stimulation. The different options are RTMS, transcranial direct current stimulation, repetitive median nerve stimulation. Then there are vagal nerve stimulation, deep brain stimulation, or electrophysiological methods to target the neural circuits in the brain. The potential benefits are earlier arousal and better functional cognitive outcome. Lastly, this is my last slide actually. So there is a neurological music therapy. What is music therapy? In neurologic music therapy in specific, it's a means of achieving non-music goals, such as improvement in speech, movement, cognition, and any other functional abilities in probably in MCS patients or even in vegetative state patients using music as a means of stimulation. The therapist focuses on different elements like melody, rhythm, tempo, dynamics in the construction of therapeutic exercise to achieve functionality. Though the evidence is limited, neuroimaging studies have shown activation of bilateral networks related to attention and memory. That's all. So there are the aspects of consciousness per se, which there are no hard guidelines on what could be beneficial or not. So we tend to use most of the things which are found to be safe and have been reported as useful in either in large scale studies or smaller studies. But there's also the concept of beyond the aspect of consciousness, these patients have other medical complications, musculoskeletal, like any other person, which also needs to be taken care. Thank you.
Thank you so much, Dr. Faiz, for a very erudite and illuminating talk on this topic. And now the session is open for question and answers. So there's a question, but before I take that, I just have one question, sort of an open-ended question to you, that supposing today one patient is referred by your neurologic colleague or maybe the intensivist for rehab. So on day one, assuming these tests have not been done before, what are the tests that you will be prescribing, and what shall be your advice to the nursing staff and to your therapist and also to your resident on day one?
Sir, day one, what state of patient, sir? Is it a completely coma patient?
It's an MCS minus patient.
Yes, sir. So just like how we described it, first I would like to see if there is any cause that is impairing his improvement, like maybe a low sodium, maybe an infection happening there, maybe anemia. Nutritional causes are very more rampant, anemia, albumin. So I would like to send for a CBC, electrolytes, and LFT. Make sure creatinine also, because we'll be giving some medications, painkillers, and spasticity measures. So this is a basic routine, and even a urine routine probably. So these are basic tests I would order. No neurological imaging at all, unless over a longer period of time they ask, we are in a position to make prognosticate, or there is a change in neurological status, then no neurological imaging at this moment. So this is a basic test I'll be doing. And with regards to what I tell my nursing staff, it would be to prevent a bed sore, and that would be the last thing you want. And the suctioning methods, a lot of people sometimes they tend to over suction, then there are bleeding, other complications associated with it. So try to understand the patient, which patients require a lot of suctioning, go for them, go intensive probably for 2 weeks. And those patients who don't, just provide nasal NS nebulizations, some humidifications, and just PT something by themselves. That's good enough for them. And I'll go for optimize of medication as well. See if they are not on any baclofen. They simply start baclofen much earlier than required, before the patient is even conscious or opening eyes. Any medication that could actually impair the consciousness, I'll look into it and make changes. And I'll talk to therapists regarding early mobilization and providing stimulation, whatever kind of stimulation. So sitting with all the supports, neck support, shoulder support, hand and leg supported, and passive range of motion, chest therapy, tilt table. This we would like to start with. And if the posture controls BP, and again, I will have to look for how the patient's BP and heart rate is. If it's not currently on maintenance with the IV fluid or something for view of hypotension, or it's not even in a state of hypertension, and he's currently not in a state of infection. That is something I would like to clear, because otherwise the chance of having a hypotension or triggering autonomic dysfunction are higher if the patient is having even a milder infection. So these are things I'd like to rule out, talk to my therapist and nurse about this. Splinting day one, maybe not, but over the time, definitely splinting as well.
Okay, thank you so much. Dr. Mulisa V has asked a question. He has asked you to kindly elaborate on the coma stimulation program.
Okay, so whatever we have, since disorder of consciousness, coma forms a part of it, and coma, even though the name is coma, I am assuming she means all of the coma stimulation programs that's been there. Like I described, whatever options we have to provide afferent stimuli, that could be cutaneous, kinesthetic, that is movement of joints, some oral pleasure feeds, or not even feed, just stimulation, auditory, visual, if at all, if it's working. So whatever we can give in terms of stimulation in a structured way, and spread over the day, actually, maybe half an hour, like a TDS stimulation program is something we have used. And just like how we discussed earlier, the other forms, and once that has been given, go for higher forms of coma stimulation, like sitting, mobilization, standing, walking, whatever it is that can provide afferent stimulation to the brain, including medications. That is what I would do for a coma stimulation.
Okay. Dr. Gaurav Gomes has also asked one question regarding the role of zolpidem for its paradoxical action. So whether we can use it, if yes, shall we give it in the morning or at night? And how long shall we try it for?
My experience has been that patients who because all the patients, once they're in the vegetative state, they have a sleep-wake cycle. And with time, we get to know that patients who are not sleeping at night, we need to give some kind of medication so that in the morning state, if at all when they go for therapy, they should not be in a sleepy position. So we have to give some medication, not have to, we tend to give some kind of medication. Common ones are clonazepam and sometimes quetiapine. These are the things I've seen. So me personally, all these patients who are on any of these sleep medications, I tend to shift it to zolpidem, and till the patient is alert. And if there is any change that we see with zolpidem, we tend to keep it for a longer time. Or once the sleep has been improved, then we tend to take it off as well.
And what's the timing of zolpidem?
Night dose.
In the night. Okay.
And I've gone through the literature. They say for the females, but these are not typically for a disorder of conscious patient, but in general, females is a 5 mg dose and adults 10 mg dose. You can basically dose slower for
females for 10 mg dose. Okay.
Yeah.
Okay. Thank you so much. I think there are no more questions. Dr. Abhishek or Dr. Pavitra Shahu, do you have anything to say?
Thank you so much, sir, for this wonderful session. And
hello. Hello.
Hi, sir.
Can you explain something about transcranial magnetic stimulation? Briefly, what is your experience on that? Do you use it regularly?
Sir, after all the things we told, this is the one thing we have directly not used in any of our patients. But while I was in NIMHANS, it has been used in psychiatric patients. And it's basically patients lies on a couch or on a chair, and there is an equipment where the advantage is they can stimulate a certain area based on where you keep it. But that's all I have the experience. We have not used it personally, sir.
Is there something like ECT, or is there a specification?
No. Yeah, there are specifications regarding where the stimulation has to be in the frontal cortex, prefrontal cortex, where the area is there. But me personally, sir, we have never used it, and I've searched, but I'm not really sure that anyone uses in India for disorder of consciousness.
Okay.
Thank you.
I would like to know. Actually, I personally would like to know if someone is using RTMS in these patients. They've been used in psychiatry and depression. And
we have used magnetic stimulation earlier, but the problem is same thing. We have not used magnetic stimulation for exclusively coma patients. That was more of research and this research, and probably while before going for a functional MRIs, we were doing it, but we have never used for therapeutic purposes for any patient.
Yes, sir. That is an exposure I would have liked to get, but I found that there's nothing in India. No one is using in India for the purpose of DOC.
Okay, one question and one comment has come up. First, the comment by Dr. Piali Mondol. So she has written that modafinil can be given at morning and melatonin at around evening, maybe between 5 to 6 p.m. to correct the altered sleep cycle. So that's her observation. And IAPMR, I guess it will be Dr. Harsha maybe, has said that, can you please explain median nerve stimulation mechanism for disorder of consciousness management?
Yes, Dr. Piali, modafinil can be given in morning and melatonin at night for correcting sleep cycles. And we have tried it, but like I told, since this is exactly the situation where we would like to try zolpidem along with it as well. And I think there are combinations of maybe zolpidem plus melatonin coming together for night. With regard to median nerve stimulation, again, we have not, I have personally not used it, but there are a lot of articles saying right median nerve. So I was checking why it's a right median nerve and not others. So what I understood was there is direct connection to the, not completely directly, but still there is significant connection to the brain centers from the right median nerve. And that is why it has been suggested for the stimulation to improve the awareness. So that's a kind of stimulating peripheral nerve to get to the brain. And that is one of the, apart from vagal nerve, median nerve has found to have that properties where stimulation can reach the brain. Now, I don't have an experience using median nerve for patients with eosinophil.
Thank you so much. And if there are no other questions or comments, maybe we can wrap up this session. Okay, Dr. Mulisa V has commented that median nerve stimulation is quite effective for coma stimulation. And this congratulations from Dr. Archana Udayan, that it's an excellent talk, and we have all agreed that it indeed is. It was very illuminating. So
thank you, sir.
Thank you so much. Dr. Shahu, over to you, please.
Hello.
Sir, just a minute, sir. I would like to just add one word that I'm a password from SVNIRTAR, and Dr. Sahu has been my HOD, and SP Das my director. Abhishek Sanyal sir was the one whom I depended when I was in the final year. It is to whom we used to go and say, sir, teach us neurology basics, something. And I'm glad that I have an opportunity here talking in front of people who basically taught me everything I know. Thank you, sir.
Okay.
Faiz, but we want more talk from you, especially on neuro rehabilitation. Still, we are, from NIRTAR side, I'm telling you that we are a bit not that much oriented regarding acute rehabilitation, neuro rehabilitation. So we will expect more talk from your side in near future.
Sure, sir. Thank you.
Thank you. Then Abhishek, you can conclude.
Yeah, thank you. Thank you so much, sir. I'm really enchanted to see Dr. Faiz to speak on neuro rehab, and he spoke really well. And I'm really happy to hear about him and how he has progressed in his life. I'm really thankful to Dr. Koustubh Chakraborty. He has been always fantastic in his academics and always been reciprocating us very socially appropriate way. So I'm really thankful to the all audience on behalf of SVNIRTAR and HOD of SVNIRTAR, that is Dr. Pavitra Sahu. He's been the instrumental and key person behind continuing this academic session. So thank you so much for joining with us. That's it. Good night for
Thank you, sir. Thank you.
Thank you. Thank you, Faiz. Thank you, Koustubh, and thank you, everybody. Thank you.